Okay. All right. Hello, everybody. Good afternoon, good evening, wherever you are. Thank you so much for joining us at the Doctor's Hour. We have an excellent speaker today, but first wanted to take a few minutes just talking a little bit about the organization. The effort here in Doctor's Hour is by the doctors, for the doctors, to make sure that we have a platform where we have free speech, free exchange of ideas, and brainstorming about how we can improve the field and move the field forward faster and more efficiently and in a safe fashion. So please bring in your questions. Please stay tuned with us on a monthly basis. Please have your colleagues and friends join us. Let's make this team stronger and let's make sure we take it to the next level. We bring to you every month great quality speakers, speakers who are experts in their field, nationally, internationally renowned, and who are making great leaps in the field of regenerative medicine and interventional pain management. One such speaker is today's presenter, Dr. Annette Ambach. She specializes in non-surgical musculoskeletal and spine care, regenerative injection therapies, sports medicine, and interventional pain management. She is a Louisiana State University trained physician who's double board certified in physical medicine and rehabilitation and pain medicine. She also has subspecialty fellowships in sports, spine, and regenerative medicine. She is a clinical instructor of medicine at the David Geffen School of Medicine at UCLA, clinical assistant professor of physical medicine and rehabilitation at Western University Health Sciences, and associate professor at the Southern California University Sports Medicine Program. A key thought leader in the field, Dr. Ambach has published numerous clinical research studies, book chapters, trained physicians from around the world, and has presented at numerous national and international medical conferences. I personally have had opportunity of working with Dr. Ambach on a few papers and have nothing but great things to say about her professionalism, about her knowledge base, and what value she brings to the field of regenerative medicine. She was selected as a top physiatrist in Los Angeles, California, by International Association of Healthcare Professionals. Dr. Ambach has also received an award by the Arthritis Foundation as Los Angeles 2018 Orthopedic Honorees. She has many years of experience in treating sports, spine, and pain conditions in various medical practice settings, and is currently in San Diego at San Diego Orthobiologic Medical Group with her associate partner, Dr. Chris Rogers. Without further ado, I'd like to welcome Dr. Annette Ambach, also known as Mary Ambach. Dr. Ambach, welcome on the Doctor's Hour, and we look forward to hearing about current evidence for stem cell therapies in orthopedic conditions. The floor is yours.
Hi, Anu. Thank you for inviting me to be a part of this Doctor's Hour. Thank you, everybody, for joining me for this month's topic. This afternoon, I'm going to be discussing the current evidence for stem cell therapies in orthopedic conditions. So the primary objective of this talk, as I have discussed, is to talk about the current evidence for bone marrow and adipose-derived stem cell therapies for orthopedic conditions. Whenever I do my regenerative medicine lectures, I always add this slide, and it's just amazing to think that our body is made of about 37 trillions of cells, and it just gives us a different perspective on how we approach treating the human body. So let's talk about the bone marrow derived stem cell therapies first. There has been a lot of published clinical trials on this topic, and in the interest of time, I will be focusing more on the more recent randomized controlled trials. I've listed other clinical trials here that involved a variety of orthopedic conditions that's being treated with bone marrow stem cell therapies, including Achilles tendon tear, rotator cuff tear, common extensor tendinosis or tennis elbow, ACL tear, bony injuries like osteonecrosis and non-union fracture, and degenerative discs, lumbar degenerative disc for the spine. So this is the first prospective randomized controlled trial comparing the use of autologous bone marrow concentrate and exercise therapy for knee osteoarthritis. This was a study by Dr. Centeno. They enrolled 48 patients with knee OA of Kellgren-Lawrence, a rating of 2 to 3, which is moderate to severe arthritis. And the control group got a regimen of physical therapy and home exercise program, while the treatment group received a bone marrow concentrate, platelet-rich plasma, and platelet lysate. This was a solution consisting of 5 to 7 cc of injectate, comprised of approximately 75% by volume of bone marrow concentrate, 12.5% by volume of PRP, and 12.5% by volume of platelet lysate. The control group was offered the opportunity to cross over at 3 months, which all of them chose to do so. They included a pre-treatment injection protocol, which was given 2 to 4 days prior to the treatment, which is an injection of a dextrose solution. The rationale for this inflammatory pre-injection was to stimulate local MSCs, as it has been shown that MSCs have been found in higher concentrations in the synovial fluid in acutely injured knee compared to a normal knee. They also included a post-treatment injection protocol of platelet-rich plasma, which was a leukocyte-poor solution of 5x concentration, a platelet lysate, hydrocortisone, and doxycycline. The autologous platelet-rich plasma and platelet lysate for the post-injection is primarily included to aid in the proliferation of the MSCs. And the platelet lysate benefits as a culture medium for MSCs, and its effects on cell proliferation has also been widely reported. A nanogram dosing of the hydrocortisone was used, and this has been previously shown to promote chondrogenesis with limited systemic response. Doxycycline was also added to the injectate, as it has been shown to decrease catabolic cytokines and improve chondrogenesis. They have 4 outcome measures that they use as listed here. You're familiar with all of this. The KSS, which includes pain, alignment, range of motion, stability, and knee function. The LEAS, which is self-administered evaluation of activity, short form 12, and the pain scale, the visual analog scale. So the results showed significant improvement in activity, pain, range of motion, stability for the treatment group compared to the exercise group at 3 months. The exercise group improved in range of motion and activity as well compared to the baseline, but this was found at a lower activity level than the treatment group. The crossover group was compared to when this group had exercise alone and to the bone marrow concentrate group. And they found that there was significant improvement in patients' functional outcome in the crossover group compared to exercise at 3 months. There was no significant difference with the crossover group and the group that had bone marrow concentrate alone. And since they did not differ significantly, they compiled the data from the bone marrow concentrate only group and the crossover group to determine long-term efficacy for up to 2 years. And they did find that there were significant improvements in pain and functionality through the 2 years follow-up after receiving the BMC treatment. There were some limitations in this study, which includes the addition of the pre-injection protocol and post-injection protocol treatment, which can confound the interpretation of the results from the BMC treatment. There was also a relatively short duration of exercise that was included. This is another randomized controlled trial by Shapiro and colleague using bone marrow concentrate for knee osteoarthritis. This was the first patient-blinded placebo-controlled trial for BMC for knee OA. They enrolled 25 patients where each patient had bilateral knee, mild to moderate osteoarthritis. One knee received BMC and the other knee received saline injection. So basically, the patient was serving as his or her own control. The patients were blinded to the treatment. The BMC had a median cell count of 34,000, but had a wide variability of anywhere from 435 to 1.4 million. They followed the intermittent and constant osteoarthritis pain scale, or ICOAP, and the VAS pain scale up to 6 months. And as you can see, the first two graphs here, there was significant improvement in both of the pain scales for both groups, the bone marrow concentrate and the placebo group. And in the bottom graph, this was a tally of the patient's responses to the activity level. And as time progresses, you can see there was improvement in their responses from a moderately severe to a mildly severe answer when they were asked if their knee pain was affected by their activity level. So their conclusion was that there was no difference between the saline and the BMC injected knees in pain and function. There were several study limitations that may help in or may shed some light as to this conclusion. There was a short follow-up period of 6 months. There was a low number of patients. As I pointed out, there was a high variability in the MSCs and the effector cells that were injected. There's multiple level 1 studies that have been published that shows that normal saline is not a true placebo, and it describes the therapeutic effects of intra-articular normal saline injections for knee OA. There's also the question of the homing capabilities of MSC. So with the similar degree of pain relief being shown here, it calls into question the mechanism by which pain relief works. There were previous studies that shows that TAG MSCs travel to sites of inflammation when delivered by IV, and also that they adhere to sites of injury when they are delivered intra-articularly. Given the degree of the arthritis in both knees, the cells administered could theoretically improve the pain and function if this is explained through the MSC homing capabilities. It was also pointed out that it is possible that the BMC injected knees improve the pain and biomechanics indirectly improving the other knee. The authors of the study recognized the limitations, and they also pointed out a selection bias towards normal weight and active patients. So it also brings about the question as to the cellular composition of bone marrow concentrate alone, if this is enough to treat OA of the knees, or perhaps do we need larger stem cell numbers like expanded autologous cells through culturing. This next study is the first randomized controlled clinical trial that uses allogeneic source for MSC for knee osteoarthritis. They enrolled 30 patients which have moderate to severe osteoarthritis. The control group received a single dose of durolane hyaluronic acid, which is a high molecular weight bacterially fermented HA. And the test group receive an allogeneic bone marrow MSC of 40 million cells. They followed these patients up to 1 year and using the scales as shown. And in addition to that, they also checked and studied the quantitative MRI T2 mapping to assess cartilage quality. So with their results, they found a statistically significant difference in the functional outcome of VAS, the WOMAC, and their oligofunctional index at 6 and 12 months. If you look at the graph on the right, the test group or the experimental group is the red line. I don't know if you can see that well, and the control group is the black line. So this is a quantitative MRI T2 mapping picture that shows a before and after treatment. And the red and yellow colors are representative of longer T2 relaxation time, which is indicative of poor quality cartilage, inflammatory tissue, and these are typically seen increased with osteoarthritis. And as you can see in the after treatment, there's less of these areas where you have the red and yellow colors, which is shown by the white arrows that shows the areas of improvement. So their conclusion was allogeneic MSC is safe and feasible, and that it results in no adverse outcome. The most common adverse outcome that they have seen is post-injection pain, which they saw in 53 to 60% of patients, and it lasted for about a week and responded to ibuprofen. They said that this was a similar frequency and control in the test group, and also as in other clinical trials using autologous MSCs. They also wanted to compare their results to other similar studies on autologous source of bone marrow MSC and adipose tissue-derived MSC. And what they did was they quantified efficacy by dividing pain relief by initial pain score as the efficacy score. And they found that the efficacy results that they had from the study were inferior to the bone marrow MSC, and similar to the adipose tissue-derived MSC trials. However, these prior studies were uncontrolled, so there's still a limit for direct comparisons. So this was a study that was done in Spain, wherein they use injection of 2 different doses of autologous bone marrow MSCs versus hyaluronic acid. They enrolled 30 patients with moderate to severe osteoarthritis. The control received a single injection of HYL1, which is also a high molecular weight bacterially fermented HA. The low dose group received 10 million MSCs in addition to the HA, and the high dose group received 100 million MSCs in addition to the HA. And this was the baseline characteristics of their patients. So each group enrolled 10 patients. And you can see the other information here. But what I wanted to point out here is the low dose group had more of the Kellgren-Lawrence 4 or the more severe osteoarthritis. Although randomization was used, this can potentially affect the outcomes of their study. So the outcomes of interest included the visual analog scale, WOMAC, range of motion up to 1 year. They measured the joint space width in millimeters through X-ray up to 1 year, and the whole organ magnetic resonance imaging score, or the WORMS score, at 6 and 12 months. So their results showed significant reduction in pain scores up to 12 months in the bone marrow MSC group compared to the control group. The range of motion was significantly improved in the bone marrow group, and the effect was seen earlier in the high dose group as early as 3 months. There was also significant improvement in all of the WOMAC subscores in the high dose BMC group. There was improved WOMAC score in the stiffness subsection for the low dose group, but not in all the other WOMAC subscores. The joint space was maintained in the high dose group on X-ray and MRI compared to the control group. And as I pointed out, despite randomization, the low dose group had more of the severe OA than high dose, which can obscure the interpretation of the results. There's several clinical trials that have been published using bone marrow MSCs to augment surgeries. And I will discuss and go over 3 of these studies, and we can briefly go over the results. So the first study was comparing HTO, or high tibial osteotomy and microfracture, versus adding bone marrow's concentrate MSCs with HTO and microfracture. So for a medial unicompartmental OA with varus deformity, medial tibial osteotomy has been shown to be an effective treatment, as it effectively unloads the medial compartment and allows for the healing of the cartilage. There has been increased survivorship that was shown in the femoral head when HTO was compared with microfracture. Other studies have shown also that when BMC was combined with high tibial osteotomy, and when MSCs were combined with microfracture, they have resulted to better chondral healing. And so thus this study wanted to investigate that. They enrolled 56 patients. All of these patients underwent the surgery. The control group received hyaluronic acid 3 weeks after the surgery, and the treatment group received 15 million MSCs plus HA 3 weeks after surgery. And the results showed that the treatment group, which had received the bone marrow MSCs, had significantly better clinical outcomes up to 2 years with post-op, and with added improvement. As you can see, it increased their IKDC scores, which was the International Knee Documentation Committee score. The treatment group also had significantly better MOCART score, which is another MRI observation of cartilage repair tissue. And this was seen at 1 year. This is another study, which is a randomized controlled trial. And this time it's investigating the results of adding bone marrow-derived MSCs to knee joints after medial meniscectomy. And all these patients, there's 55 of these patients, underwent a partial meniscectomy, which they defined as at least 50% by volume. The treatment group received the interarticular injection of allogeneic MSCs a week after surgery. Group A, which is the low-dose group, received 50 million of these MSCs in the HA solution, and Group B, the high-dose group, received 150 million of the MSCs in HA solution. The control group injection just received the HA solution. So safety, clinical outcomes, and meniscus volume were followed at different intervals throughout these 2 years. So with regards to safety, they actually did some different testing, immunologic testing, hematologic testing, and urine testing. And all of this testing in the patients showed no clinically significant trends. There were several adverse events that were noted, but none of them led to treatment termination. There was a significant improvement in the pain scale at 2 years for the low-dose group, and at 1 to 2 years for the high-dose group. There was also significantly increased meniscal volume, which they defined as the 15% threshold increase in volume determined by the quantitative MRI. Interestingly enough, they had increased meniscal volume. More of them found 24% in patients in the low-dose group, and only 6% in Group B, which is the high-dose group. There were some limitations in the consistency of the MRI scans from visit to visit, and also from the different centers and the types of MRI machine with regards to 1.5 Tesla versus a 3T Tesla. There was also some limitations in the differences in the osteoarthritis in these knees of the patients that were enrolled, since this was not controlled. So this is a study on evaluating core decompression for femoral head osteonecrosis versus core decompression and autologous BMC. This was a randomized prospective study where they enrolled, they used 25 hips with an ARCO2 rating. ARCO is the International Association of Osteonecrosis. It's a femoral head osteonecrosis rating, and ARCO2 is when you see sclerosis and osteolysis in the femoral head, but no flattening. And all these patients underwent core decompression. They divided these patients into the cord decompression group and the cord decompression plus the bone marrow concentrate group. The BMC was injected intraoperatively right after they removed the cord decompression, removal of the wire. They injected the BMC. And the results showed significant decrease in pain and function using the visual analog scale and the high-risk hip score in both groups, but they didn't find any statistically significant difference between the two groups. They also measured the MRI volume of necrotic zone and ARCO rating at 1 year and 2 years, and they also didn't see any significant change in volume of the femoral head necrosis. This is a table of prior studies that has also evaluated the use of cord decompression and bone marrow concentrate for femoral head osteonecrosis. The most known of this is most likely Hernigau's paper here. The other two groups are included by Ganji and Zhao. And all of these prospective studies showed a head survival rate that was increased in the bone marrow concentrate treatment group, except for this study, which did not show any significant difference when adding the bone marrow concentrate. This current study is had a very strict inclusion criteria, and they only included ARCO2 hip osteonecrosis, and they excluded ARCO1, which had normal X-ray and CT, but had some MRI changes of osteonecrosis. This was excluded from the study, and ARCO1 has a better prognosis. So this might have an effect on their clinical findings. There has been different study protocol with these 4 different studies, so meaningful and direct comparison is also difficult to make a conclusion from. This is a recently published systematic review of bone marrow concentrate in musculoskeletal disorders. So they got online review from PubMed, Medline, and Cochrane databases of trials from 1980 to 2016, and they included the inclusion criteria included human clinical trials using bone marrow concentrate for musculoskeletal conditions, and excluded animal studies, basic science articles, reviews, etc. They identified 986 articles, and 46 articles met the inclusion criteria, which is shown on the table on the right of the screen. And these were the clinical indications for which the bone marrow concentrate was used. And as you can see, there were several of them. There's a lot of bony injuries and pathologies, some tendon injuries like rotator cuff problems, Achilles tendon, tennis elbow, ligaments like ACL ligament, and degenerative disc for discogenic pain. And what they found was only 30% of all the studies that they have included that met the inclusion criteria provided quantitative metrics of the composition of the BMAC final product. Their reporting preparation protocols was highly inconsistent, and the studies did not provide sufficient information for the protocol to be reproduced. As we can see now, there's lots of data that are coming out on a regular basis regarding these regenerative therapies, and if we want to move this field forward, we not only need high quality data, but we also need to standardize our methods and reporting measures. So let's now move on to the adipose-derived stem cell therapies. Again, I will be focusing my discussion on the randomized controlled trials. There are other clinical trials which you are probably aware of with regards to the use of these therapies for lateral epicondylitis, rotator cuff disease, osteoarthritis for the ankle, and talar lesions. And adipose tissue cells, whenever you look at the literature on studies for these therapies, there's a lot of different terms and different kinds of cells that are being tossed about. There's a lipoaspirate processed cell, adipose stromal cell, adipose-derived adult stem cell, etc. So the International Federation for Adipose Therapeutics and Science, which is IFATS, and the International Society for Cellular Therapy published this joint statement to characterize these different cell populations and establish minimal definitions. And this is a good read if you are entertaining using this for your practice. So just to clarify furthermore the different terms and to differentiate SVF from adipose stem cells. So we start with the lipoaspiration, and this gets microfragmented or emulsified in centrifuge. The lipogem device is an example of a microfragmentation, and the tulip device is an example of an emulsification and centrifugation. Or you can further process this tissue and go through enzymatic processing and digestion and centrifugation to separate the SVF fraction, which stands for stromal vascular fraction, which is a heterogeneous mesenchymal population of cells. And it includes adipose stromal cells, hematopoietic stem cells, endothelial cells, erythrocytes, fibroblasts, monocytes, etc. And these SVF cells, when you seed them into culture and you purify them further using a combination of washing steps and culture expansion, it produces this adherent cell population of cell that's termed adipose-derived stem cell or adipose tissue-derived stromal cells. These ASCs are a less heterogeneous population of cells than the SVF cells, and they include multipotent cells with the ability to differentiate into adipocytes, chondrocytes, and osteoblasts. There has been several review articles that summarizes the safety of adipose MSCs in knee osteoarthritis, and I've listed the more common and important ones here for you to read and for your references. Song and company, after conducting in vivo and in vitro preclinical studies, have proceeded with this randomized trial, double-blind phase 1 trial, using adipose-derived expanded tissue, MSC injection tissue for their study. And it's the first attempt at the repeated injection of MSC in a clinical trial. So they enrolled patients with KL2 or 3 NEO-A. They used an autologous culture expanded MSC injection, and they randomized them to 3 different groups, the low dose 10 million, mid dose 20 million, and the high dose 50 million cells. They performed ultrasound-guided injection at 3 weeks and 6 weeks after the lipoaspiration. And they followed them up for 48 weeks. In the phase 2 part of the study, 14 out of these 18 patients consented to proceed with the 3rd injection, who received the high dose of 50 million cells. And they followed these patients up to 96 weeks. They used these clinical outcomes of WOMAC, numeric pain rating, short form survey, and they also performed MRIs for these patients for 96 weeks. And they have shown significant reduction in the WOMAC scores, significant improvement in their pain ratings and their short form survey. They have shown no serious adverse effects. Again, the most common complaint was pain and swelling that lasted less than a week. The high dose group showed more significant effects compared with the other 2 groups on pain relief and function. which was sustained longer. The effects were sustained longer. On the MRI, there was significant increase in cartilage volume by 24 to 48 weeks. And there was a greater increase in cartilage volume in the high dose group and after the third injection dose. Excuse me. This study was the first to demonstrate the safety and potential benefits of human adipose-derived MSC's therapy with the long-term follow-up of up to 2 years with repeated injections. This is the next study by Hong and company, which is a double-blind randomized clinical trial enrolling 16 patients with bilateral knee osteoarthritis. All of these patients receive bilateral knee arthroscopy under general anesthesia, and unstable cartilage lesions were debrided as well. One knee received 4 ml of the SVF fraction, and the other knee 4 ml of hyaluronic acid. And they followed these patients with these functional outcome measures and MRI up to 12 months. The SVF group showed a VAS rating and range of motion, which was improved at 12 months. And this is the red portion of your graphs here. And the HA group showed VAS and range of motion improved at 1 month, but after 1 month, they worsened. With regards to their WOMAC scores, the SVF group had improvement of their pain and stiffness subgroup at one year, and the HA group also improved with the WOMAC pain subgroup at 1 month, but then worsened. The SVF group also had MRI changes that were significantly improved, while the HA group had MRI changes that were worsened. 69% of the SVF group showed cartilage repair versus 6% in the HA group. And the MRI pictures that you see on the left here, these were 3 SVF-treated knees from baseline to 12 months. And they followed them up. And as you can see with the subsequent images, it showed complete repair and filling of the defects, as well as good integration of the adjacent cartilage and underlying bone in the coronal, transverse, and the sagittal planes. This is a study, a randomized controlled trial of using the stromal vascular fraction injection for chronic Achilles tendinopathy. So they enrolled 44 patients. 23 of them received a platelet-rich plasma injection using a leukocyte-rich 4x concentration of PRP, and the other 21 patients received SVF injection. These patients had received an injection of 4 cc of either PRP or SVF injected into the lesion intratendinously and peritendinously using musculoskeletal ultrasound. They followed their visual analog scale, their VISA-A outcome measure, the American Orthopedic Ankle and Foot Society ankle hindfoot score, which combines functional outcome and pain, short form survey, and they followed them at various intervals up to 180 days. The patients were given crutches. For the first 24 hours, they were allowed to walk with crutches. There was no specific physical therapy protocol given. They were instructed to progressively resume activities and exercises. So the results showed significant improvement of PRP and SVF groups compared to baseline for up to 6 months. The clinical outcomes was significantly better in the SVF group at 15 and 30 days. However, beyond this point, there was no significant difference between the 2 groups that were shown. So their results showed no significant improvement also in the MRI and ultrasound at 4 and 6 months, they measured the maximum diameter in millimeters in the Achilles tendon. And they showed no serious side effects nor adverse events. So in conclusion, the study concluded that both PRP and SVF were safe, effective treatments for recalcitrant Achilles tendinopathy, and the SVF treated group had quicker results, and thus suggesting that the treatment can be done in patients who needs earlier return to play or earlier return to their activities of daily living. So as we can see, there's limited spine data for stem cell therapies. The American Society of Interventional Pain Physicians recently published this guideline with regards to the evidence for regenerative therapies for spine, and they use a qualified modified approach to grading evidence. They included the panel of experts from various medical fields using a randomized controlled trial, meta-analysis, systematic review, etc. And their conclusion was that intradiscal injection of PRP and MSCs was level 3 or fair evidence. And this was a step in the right direction in organizing data and promoting standardization, and hopefully will encourage the production of more future high-quality studies on spine. We have an ongoing study in our effort to contribute meaningful results to the current spine data. We have an ongoing study that's led by Dr. Novani with regards to a bone marrow concentrate and PRP for lumbar intradiscal injections. And this is a multicenter randomized controlled trial for internal disc disruption. And we're dividing the patients into 3 groups. The control group receives a trigger point injection. The other 2 groups will receive a PRP injection and bone marrow concentrate injection. There's a crossover design wherein the PRP or the bone marrow concentrate group will cross over at 6 months if they don't have any improvement, and as well as the treatment group is being randomized to either PRP or bone marrow concentrate group at 3 months. So hopefully, we're about 6 months into the study. Hopefully we can get meaningful results to contribute to this current limited data in spine that we have for regenerative therapies. So in summary, as we all know, these biologics are a revolutionary treatment. They have tremendous potential. And as I have harped over and over again, there's a need for standardization and collaboration to move the field forward. There's a need for more data. In our clinic, we're using Data Biologics, which is a regenerative medicine registry. And it's a very easy data collection wherein the surveys are automatically scheduled at predetermined times, and the patients are given a reminder to complete their surveys on their mobile device or their iPads. And this uses a standardized functional measurement depending on the body region, and you can generate your report on outcome measures anytime. And it's a very useful tool for us. Not only does it make it easier for us to track our outcomes and hopefully present it in clinical trials in our studies, but also it's something that we can objectively refer to when we're talking to our patients with regards to clinical outcomes with these therapies. So it has been very useful in those discussions. And with that, I conclude my talk. Thank you very much for your time and for staying with me.
Thank you, Dr. Ambach. That was an excellent presentation. Learned so much along the way with all the slides and information that you had. Got it. Thank you so much, Dr. Ambach. Thank you, everybody who has joined the webinar. We started a little late and ran a little bit late. Apologize for that, but it was such a great talk, and I learned so much, as all of you did, I'm sure. So, Dr. Ambach, once again, thank you for your time. We look forward to having you again some time on this platform. Up until then, thank you so much. And to our listeners and viewers, please keep logging in. We are going to continue bringing great speakers to you and excellent topics. And bring your friends and colleagues onto the Doctor's Hour. We want to promote regenerative medicine in a way that's effective, safe, and are able to move the science forward by having expert opinions from all around the world. So thank you once again, everybody. Dr. Ambach, it was a pleasure having you. Thank you.
Thank you, Anne. Pleasure's mine.